السلام عليكم ورحمة الله. طبعا في الأول أحب أشكر الأستاذ الدكتورة طبعا إيناس شلتوت على دعوتي. سعيد بوجود طبعا التشير بيرسون، وبشكر نوفارتس على دعوتي إن أنا أكون موجود معاها في السيمبوزيوم اللي إحنا هندسكاس one of the important clinical topics في المانجمنت of diabetic patients اللي هي hypertension and diabetes. And I prefer to address my message through an index case, as we see here, Mr. Bedri. He is 40 years old male. He is a banker with long working hours and smoker. He is newly diagnosed with type 2 diabetes and hypertension. He had a history of recurrent stone pathogens with recurrent GTI, physical examination, mildly obese, BMI is 30 kg meter square. He has a repeated blood pressure 150 على 90. No evidence of retinopathy, and the remainder of the physical examination is unremarkable. His lab results showed the current A1C is 7.4, fasting 160, 2-hour postprandial 240, albumin creatinine ratio 30, estimated GFR 79, urine analysis have some pus cells, and the lipid profile is normal. The question now. In addition to advising lifestyle modification, which one of the following treatment options you find it most appropriate and why? عيان جاي لي newly diagnosed هديله ايه؟ plus lifestyle. Add metformin, DPP4 inhibitor, and metformin combination, galvasmet. Or GLP-1 receptor agonists, sulfonylurea, bioglitazone, SGLT2 inhibitors, or basal insulin, and I think all the options for treatment of diabetes are here for the selection. If we refer to the guidelines, as we all know, after metformin initially, and the recommendations, American Diabetic Association clinical practice recommendations, the choice based على clinical compelling needs. First, address the questions of cardiovascular risk, CKD, congestive heart failure, to select between GLP-1 receptor agonists or SGLT2 inhibitors. Otherwise, if no, you can give the drug based on the compelling needs for reducing the rate of hypoglycemia, reducing or avoiding weight gain, or the cost. If we have a look here, DPP4 inhibitors in general is found to achieve or to have additional glycemic control, whatever the compelling need for treatment of glycemia. But very important recommendations from the ADA clinical practice that early combination therapy can be considered in some patients at treatment initiation to extend the time for treatment failure. This data based on the verified trial that the early combination of gliptin plus metformin for the early treatment of glycemia versus the monotherapy showed a significant benefit. And the data, as we know, is specific for the VELDA, as they mentioned here in the text, vildagliptin plus metformin specifically, and have not been generalized to other agents. Data from the verify the vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes. This to study the durability of glycemic control for early combination therapy, vildagliptin metformin versus sequential metformin monotherapy in newly diagnosed type 2 diabetes. This is the design of the trial, 3 weeks run in and 2 different arms, combination, early combination vildagliptin plus metformin versus metformin plus placebo for period 1 till the A1C exceeding 7% 2 times, and proceed for period 2, the addition of vildagliptin for the monotherapy, and when failure to achieve the target, we will go for the period 3, the addition of insulin. The data was statistically significant, showed a reduced almost 50% that in early combination treatment group compared to the monotherapy group for treatment failure and duration. The other important point, that time to secondary failure showed a relative risk and a significant reduced early treatment combination by 26% with early combination versus sequential monotherapy with metformin. This is an important statistically significant data. And another important from the study questions raised, do young onset diabetics benefit more from the early combination? The median age in the verified was 55 years old. So there was a chance to divide the patients before young onset diabetics before the age of 40 and late onset diabetic after the age of 40 to test these important questions, who may benefit more. We found that both groups, young onset and late onset diabetes, achieve a statistically significant benefit on the initial period. However, for the secondary failure, the young onset diabetes have a significant reduction for the secondary endpoint failure, nearly double the late onset diabetes. And this leads to the conclusion that in patients newly diagnosed with young onset diabetes and with HbA1c 6.5 to 7.5, the verified study showed that early combination strategy of vildagliptin metformin improved the attainment of glycemic target with durability and delayed treatment escalation compared with the sequential treatment of metformin followed by the addition of vildagliptin. How this done? Another important data sub-analysis, the effect pre-specified, the effect of beta cell function in the newly diagnosed type 2 diabetes after treatment with vildagliptin and metformin. Pre-specified data from the study to test the beta cell function by the HOMA B cell function showed that the combination adjusted mean change for beta cell function from the baseline. The adjusted change from the baseline was 17.2 for early combination versus minus 2.0, which showed a statistically significant improvement or at least less reduction in beta cell function with the initial and early combination of vildagliptin metformin versus the monotherapy with metformin. With the verify, we have a real benefit on numbers. 56% were able to maintain the glycemic control of A1C less than 7 at 5 years in the early combination therapy. 57% on the early combination strategy were able to achieve HbA1c less than 6.5 at 3 months and keep it for at least 1 year. 48% young onset patient in the early combination strategy delayed the initiation and the secondary treatment failure versus the sequential approach. The beta cell function showed improvement based on HOMA B in the early combination versus the monotherapy. Back to our patient, he's not only newly diagnosed diabetes, but even he has also starting hypertension. As we see here, his blood pressure is 150/90. So the question is, now, what's the approach for his blood pressure control? How should he be treated? Lifestyle modification only? Thiazide diuretics to add? Cardioprotective beta blocker? ARB? ACE inhibitor or calcium channel blockers? What did the guidelines say? And this is the clinical practice recommendations from the EDE for cardiovascular risk management. As we see here, hypertension is a common diabetes comorbidity, and we saw it a lot in our clinical practice. Hypertension is a major risk factor for atherosclerotic cardiovascular disease and microvascular complication. Antihypertensive treatment reduces the atherosclerotic cardiovascular disease, heart failure, and microvascular complication. Patient with diabetes and hypertension, the blood pressure target should be individualized based على cardiovascular risk, potential adverse effect of the antihypertensive medication, and the patient preference, so that patient at high risk of cardiovascular disease ونقول عنده established atherosclerotic cardiovascular disease أو atherosclerotic risk more than 15%, the target for blood pressure goal less than 130/80. If the patient has a low risk with atherosclerotic cardiovascular risk less than 15%, the goal is less than 140/90. But the lifestyle modifications should be started with the blood pressure more than 120/80, and this lifestyle modification includes weight loss for overweight and obese, dietary approach with DASH diet and low salt, and increasing potassium intake with moderation of alcohol as an important lifestyle intervention, plus the increasing physical activity. However, patient with blood pressure more than 140/90, in addition to the lifestyle, we have to prompt initiation and timely titration of pharmacological therapy. This pharmacological therapy better and or should be with double treatment if the blood pressure more than 160/10, with 2 drugs or a single pill combination of drugs to reduce the cardiovascular event in patients with diabetes. The data or the treatment recommendations recommend one of 4 classes: the ACE, the ARBs, the TZDs, and calcium channel blockers, with evidence of reduction of cardiovascular morbidity and mortality. Actually, multiple drugs needed to control blood pressure in patients with diabetes, but be cautious that the combination of ACE and ARBs is not recommended or contraindicated. ACE or ARBs should be the first if the patient has evidence of any sort of proteinuria, micro or macro proteinuria. And if one class is not tolerated, the other is preferred. And this is the exemplary approach recommendation for treatment, patient of hypertension and diabetes. If the blood pressure more than 140/90 but less than 160/10, start with 1 drug. If the patient has evidence of albuminuria, you should start with ACE or ARBs. If the patient has blood pressure more than 160/100, start with 2 agents. If the patient has albuminuria, one of these agents should be ARBs or ACE plus other combinations. If the patient is controlled, we will continue. If the patient is not controlled, we have to add another drug from another group with complementary effect. If the patient is not controlled, you have to think the mineralocorticoid receptor antagonist or refer for hypertension specialist. Actually, the evidence of control of hypertension in patients with diabetes is a lot of trials, and this is some examples of the trials show that blood pressure control reduces the atherosclerotic cardiovascular risk in patients with diabetes. UKPDS showed from the analysis that for every 10 millimeter mercury reduction systolic blood pressure has significant statistical reduction of all diabetes-related endpoints and diabetes-related death, microvascular and myocardial infarction. Actually, the renin-angiotensin system and ACE specifically play a central role in the pathophysiology of renal disease in patients, which end with the reduction of nephron mass, glomerulosclerosis, and end with chronic kidney disease. The evidence for benefit of ARBs reduction or use in patients with hypertension or hypertension with proteinuria is a lot, and a lot of trials, IDNT, ERMA, RENAL, and the MARVEL. The MARVEL trial is microalbuminuria reduction with valsartan in patients with type 2 diabetes, and showed a significant reduction in albuminuria in the arm of valsartan versus the amlodipine as a calcium channel blocker over a period of 6 months. Valsartan in hypertension has a significant, a lot of data, and as we see here, the ARB's differential analysis and intra-class differences according to the FDA and EMA recommendations will find that valsartan has an indication for treatment of heart failure, hypertension, heart failure, treatment post-MI, and has an evidence with reduction of morbidity and mortality compared to the other ARBs. Hypertension in Egypt, we have frustrated actually data. As we see here, only two-thirds is aware that they have hypertension. As we see here, unfortunate, a small number is treated for hypertension, تقريبا الربع, and more frustrating that the controlled presents a very small fraction of patients with hypertension, and this needs to have a lot of intervention. One of the important reasons for this poor control and awareness that the disease is asymptomatic, and actually the using of a single drug with a single mechanism may result in these poor results. Advantage of multiple mechanism, efficacy-wise, multiple mechanism therapy is in general leads to targeting better for targeting many of the mechanism or multiple mechanism therapy results in additive reduction for blood pressure. Complementary drugs with a different mechanism leads to control for blood pressure, and again the components can potentially neutralize the counter-regulatory mechanisms. Safety and tolerability may be beneficial with the combination treatment, reduced the dose, lower dose, and with this lower dose we can attenuate the adverse effect of the drugs. This is an example of the counter-regulation and balances. ARB بتقلل الراس systemic sympathoneurotic system. طبعا الكالسيوم channel blockers بتزودها نتيجة الفازو dilations. With this counter-regulatory balance, we will find that the calcium channel blockers with the RAS, we will have an important additive effect with the reduced edema as an important side effect for the combination of RAS and calcium channel blocker. Combination therapy used can initial treatment for diagnosis for high risk patient mark elevate blood pressure for uncontrolled with monotherapy. طبعا عندنا داتا كبيرة. One of these data من X effect study. X effect study compare the efficacy and tolerability amlodipine valsartan versus amlodipine in patient with stage 2 hypertension. This is the drug or the trial of the design. Valsartan, amlodipine versus amlodipine alone. It showed a significant reduction in blood pressure, and this results more reduction أكثر من حوالي 30 mercury in patient with diabetes, superior with valsartan amlodipine combination versus amlodipine. Patient with grade 2 hypertension, moderate hypertension, significant reduction amlodipine versus valsartan, and again patient with severe hypertension, mean systolic blood pressure كان أقل في الcombination valsartan amlodipine versus amlodipine alone. These data give a very important number أكثر من 53% of patients achieving the goal with this combination. This data was reduced the edema as an adverse effect with valsartan amlodipine. Another important data came from Egypt for the X-Forge or the combination valsartan amlodipine hydrochlorothiazide trial conducted by Professor Adil Al-Atrabi, and it showed that with this patient we have a significant benefit reduction على blood pressure with this combination compared with other treatment not controlled على other drug treatment, and out of 10 patients can reach the blood pressure goal with this combination in our patient. Single sitting pulse is significantly decreased after 2 weeks of treatment. 95% of patients showed excellent and good tolerability with the X-Forge HCT for this trial. In the conclusion for that trial, X-Forge showed a significant blood pressure reduction after 2 weeks in Egyptian population. 8 out of 10 patients reaching their goal, with high among patients reaching up to 95%. Actually, a lot of data with valsartan from different trials showed a very significant outcome for the control of blood pressure, plus indications in the other cardiovascular areas. Thank you very much for your listening.
بنشكر الاستاذ دكتور رضا حلاوه رئيس اقسام الباطنه جامعه عين شمس فور هيز elegant توك، وزي ما عودتنا حضرتك. انا ليا سؤالين بعد اذن حضرتك لو تسمح لي، وبعد كده نسيب الاسئله للاودينس. السؤال الاولاني بالنسبه لل DB4. What about DB4 with diabetic patient with COVID-19? بالنسبة للسؤال الثاني، what about ال DB4 in do you think is there a good benefit in cardiovascular disease with DB4, especially type 2 diabetes and heart failure?
يعني طبعا it's easy to answer the second questions. طبعا ال DB4 inhibitors in general is neutral for the cardiovascular outcome. All the data, it's neutral, no despite the evidence shown before the outcome trials that they have a good effect على surrogate or comorbidity, but by the end they are neutral. For the DB4 in COVID and diabetes, actually no harm, but there is some data showed recently that there may be benefits of patients using the DB4 inhibitors in diabetics with COVID infection.
شكرا. حد له اي سؤال يا جماعه؟ شكرا، وبنشكر شركه نوفارس على السيمبوزيوم والدكتوره ايناس.
Thank you.
ندعو الساده رؤساء الجلسه النوفو سيمبوزيوم.